Well, good day, everyone. My name's Trevor Duke, and I want to thank the World Federation for their kind invitation to present at this meeting. I agreed to present, and then unfortunately late this week I'm going to be in a remote area where the internet is very unreliable, and I almost certainly won't be able to do video conferencing. So I thought I'd pre-record this talk, and hopefully it can be played. I may have audio connection where I am, but I doubt it. So I've been asked to talk about oxygen provision in low-income settings, and I'm privileged to talk with my colleagues from Ghana and the USA, and my friend Hans from Germany in this session. So we'll start. Many of you will be familiar with locations like this. This is a hospital called Kainantu in Kainantu District Hospital in the Eastern Highlands of Papua New Guinea. On many months of the year, it's full of children who have acute respiratory infections. These days, most often due to RSV, formerly RSV and other viruses, and formerly it was due to pneumococcus, of course, and Haemophilus. But while the epidemiology of childhood pneumonia has changed a lot, the burden of childhood pneumonia is still very prevalent, and you can see all of these babies receiving oxygen, and I'll talk about the mechanism by which they're receiving oxygen throughout this talk. I first of all want to show you these short videos of a small baby in Mount Hagen, which is also in the highlands of Papua New Guinea, and I just want you to look at this small baby who has a respiratory infection, has pneumonia, and you can see that her oxygen saturations, she's a bit awake at the start, and then her oxygen saturations are 52, and she's falling progressively to sleep, and her oxygen saturations dip below 50. And of course, at that point, one should do something. This is what was done, of course, and this is 1 minute later, less than 1 minute later, and you can see her oxygen saturation is 98%. Her heart rate's come up a bit, and she's awake. She's now awake. And this is exactly what was done. Most people in Western countries would think a child with an oxygen saturation of less than 50%, they would need intubation and possibly ECMO or something extreme like that. Well, this baby needed just 1 liter of oxygen per minute via an oxygen concentrator. The problems of provision of oxygen in low-income settings, I'm sure, are well known to many of you practitioners who work in those settings. I'll just give some ideas of the traditional ways of giving oxygen, which was using cylinders. In some countries there are multiple cylinder oxygen companies, and in some countries there's a monopoly. And in Papua New Guinea, at least some years ago, where cylinders was the only mechanism for giving oxygen, it was costing the average provincial hospital about $100,000 per year, plus the transport costs. And you can see in this picture here, there's a truck full of oxygen cylinders, and these men here are having to reinforce the bridge to get the truck over to get to the health facility to deliver oxygen to the health facility. Lots of logistic problems. Cylinders, of course, run out, and it's not just a cylinder you need other equipment as well, and a flow meter and a regulator to regulate the pressure. You need oxygen tubing, and you need a nasal interface of some sort, a mask or nasal prongs. And so even giving oxygen by oxygen cylinders is not a simple process in remote areas. I want to just say something about it. It harks back to the videos that I showed you earlier, and that is the probability of death in severe pneumonia relative to the degree of hypoxemia at a time a child presents. And I found this study, which was done a long time ago now. I found this study very instructive because it taught me a great deal about the management of severe pneumonia. So all these children had oxygen saturations less than 85 when they presented, and you can see that their predicted probability of death was about 5%. But as their oxygen saturation fell, it rose considerably to over 20%. But interestingly enough, even at an oxygen saturation of 50%, which I showed you the video of a baby before. This is 700 children who had severe pneumonia and an oxygen saturation of 85%. Even with a saturation of about 50%, the mortality rate was about 10%, 0.1 probability of death. So a 10% risk of mortality. So that tells you that if you provide enough oxygen to children, even when they have severe hypoxemia, the vast majority of them will survive. This is another cohort of children, over 1,000 children with very severe pneumonia, what WHO at the time called very severe pneumonia. And you can see this is the days to resolution of hypoxemia and the proportion of children. It's like a Kaplan-Meier curve for the resolution of hypoxemia. And what you can see is that the vast majority of children, or the majority of children, have a resolution of hypoxemia in the first few days. But there is a long tail, and the long tail includes that if for children with very severe pneumonia who have hypoxemia, about 20% will still be hypoxic at 10 days. So normally we would have given 5 to 7 to 10 days of antibiotics, and we would think that the child's well enough to be discharged. But 19 in this cohort, 19% of children remained hypoxic, and of those, 83% survived if you kept giving oxygen. At 20 days, 6.8% remained hypoxic, but yet when we kept giving oxygen by nasal prongs, the only way we had at the time, 83% of children survived, and even up to 30 days, just over 3%, 3.5% of children remained hypoxic, but still, if they got oxygen for long enough, then 84% survived. Now, this is at altitude. This is at 1,600 meters in the Eastern Highlands province of Papua New Guinea, where pneumonia is very common, where hypoxemia is really common, and it's more prolonged than it is in coastal areas. So there's that rider about the proportion of children with hypoxemia persisting at 10, 20, and 30 days. So oxygen cylinders are a logistically complicated and expensive way to give oxygen in remote areas. And so oxygen concentrators, which I showed you before, may be a better way. And oxygen concentrators, as I think you know, they extract atmospheric air, they remove nitrogen, it goes through canisters which are filled with zeolite crystals. Zeolite crystals remove the nitrogen, and what you're left with is a concentrated form of oxygen. And a good oxygen concentrator will deliver 93% oxygen or more. So perfectly good enough for the management of children who have pneumonia. In the early 2000s, we did a large study of the use of oxygen concentrators in the highlands, mostly in the highlands of Papua New Guinea. This involved 5 hospitals with more than 11,000 children with pneumonia, and the pre-intervention case fatality rate before oxygen concentrators and pulse oximeters was 4.97, so nearly 5%, and post-intervention it was 3.2%. So a substantial reduction, a 35% reduction in the risk of pneumonia mortality post-intervention when a program for the introduction of oxygen concentrators and pulse oximeters took over just the use of oxygen, the provision of oxygen using cylinders and no pulse oximetry. I won't go through the cost per life saved, but it is actually a very cost-effective system when you're just using oxygen concentrators and pulse oximeters. Very comparable, actually, to almost any other intervention you can imagine for the prevention or management of pneumonia, including pneumococcal vaccine. The problems are that oxygen concentrators require a 24-hour reliable power supply, and power is not always reliable in the remote settings that I've indicated. And more importantly, perhaps, is that even in settings where mains power is available, we found that there were often several hundred power outages per day. They're often transient power outages of just a few seconds or even less while a generator kicks in, and there can be power surges and drops in power that damage the oxygen concentrators. And I think this is one of the reasons why most oxygen concentrator programs have looked successful in the first year or so, couple of years, and then failed, is because in those settings, power fluctuations damage oxygen concentrators. This is a type of setting. This is Pomio Hospital in East New Britain Province. It's a district hospital. It's a place where oxygen provision is really difficult because it's a maritime province. It's hard to get oxygen on boats and get it over there, and it's to fly oxygen into an island province. You need to charter a plane because oxygen cylinders are largely prohibited in commercial airlines. Some time ago, we looked at what was required at a district hospital level to provide oxygen adequately, and we started a large project really that went over 10 years, looking at exactly what was required to provide adequate oxygen. I won't go through all of this, but as you can see, it's a bit like what I mentioned for oxygen cylinders. Provision of oxygen using oxygen concentrators is a complex intervention, and if you're going to do it properly, you need to have a source of reliable power and ideally renewable power. And what we chose for this project was solar power. Not surprisingly, in many tropical countries, solar power is highly effective. It doesn't just require oxygen equipment, but power and training and guidelines and maintenance and systems for procurement and replacement. It's a complex system that requires both clinical and health system inputs. The power source that we designed for this project had to be able to provide oxygen even when the sun wasn't shining, and it needed to provide enough not just for running oxygen concentrators, but also for running a few other essential services within the health facility, such as running a suction machine for the management of children with pneumonia, running a vaccine refrigerator if there wasn't already a solar-powered vaccine refrigerator, for being able to charge the nurse's mobile phone so she could communicate with the paediatrician, etc. A small amount of additional power. But it was designed to supply 11.4 kilowatt hours per day, and that was the daily average load that we calculated a relatively small district hospital would require to run 2 oxygen concentrators and those other items I mentioned. It's surprising how even in hot climates, the peak sun hours can be relatively low. And so often you see solar power being attached onto roofs of buildings. Of course, that's the standard way. But if you do that, then the location and aspect of the existing building will dictate how much sun and solar power you can generate. So we used separate solar structures that were at a specified tilt angle and maximize the power that was generated. 18 240 watt panels, and we used a battery with 3 days of autonomy, such that if there was no sun, then there was still reliable power to run oxygen concentrators. You just can't run out. This project was conducted in 36 health facilities, remote health facilities, mostly in the highlands of Papua New Guinea, but in 9 provinces in total, and where the population is over 2 million. The combined population is over 2 million people. These are the remote provinces in Papua New Guinea in the highlands, and they're all outside the provincial capitals, and they have a very high burden of pneumonia. The challenges of doing so are considerable. I'm sure, the problems of transport and logistics in such settings. This is a truck that was carrying the oxygen equipment and solar power, and the difficulties of getting equipment and logistics through. And at least, though this only has to happen once, rather than the transmission or the transport of oxygen cylinders. These were the structures on which the solar panels were built, and you can see the construction. As I said, training is very important, and teaching people about how to look after oxygen concentrators. The lack of that, I think, has been another reason why oxygen concentrator projects have failed after a couple of years, because there's not enough capacity among healthcare workers to look after concentrators themselves. So training becomes extremely important, teaching nurses and community health workers. The result was very encouraging, I would say. Again, this is a very large study of nearly 20,000 children who had pneumonia. And pre-intervention, the mortality rate was 3.69%, and post-intervention, 1.76%. So a 50% reduction in the incidence rate ratio of death from pneumonia. As well as that, these are all in remote health facilities. As well as that, far more children were able to be managed in remote health facilities with solar-powered oxygen, and we calculated it prevented over 1,500 referrals over a 3-year period. So not only were there fewer referrals to the provincial hospital, but also the mortality rate was lower. So it means that keeping children in a district hospital, as long as there's sufficient oxygen and training and healthcare worker support and all the other things that are required, is a safe thing to do so. In fact, it lowers mortality by doing that, and avoids referrals. So a very cost-effective thing to do. Now, before the pandemic, I calculated that an average hospital, so this is back in about 2012, I calculated that the average busy provincial hospital used 38,000 litres of oxygen per day. And a district hospital, like I showed you before, Pomio and other places, they require about 17,000 litres of oxygen per day. And this was calculated based on many studies measuring oxygen use by cylinders or concentrators in examples of these hospitals. And we concluded that concentrators were the most effective method of providing oxygen. However, there are problems with even oxygen concentrators. And the first one is that maintenance of oxygen concentrators is essential. And another reason why large oxygen concentrator projects done in many countries, if you go back and look at them, they've largely failed after a few years. And a major problem is the lack of biomedical technician capacity. The second problem is that solar power is very expensive. While oxygen concentrators are cheap and pulse oximetry is cheap, solar power in many countries is very expensive and multiplies the cost of giving oxygen many times. In 2020 and 2021, oxygen became a global issue because, in large part, it became an adult problem. Paediatricians and healthcare workers looking after children for decades had known that hypoxemia and oxygen provision was a big problem. But in 2021, it became a global adult problem. And I think that caused the world to think about the importance of oxygen. Now, remember I said that back in 2012, I had calculated what a busy provincial hospital on an average day and a district hospital on an average day would use in terms of oxygen. Well, these are the real measurements of what busy provincial hospitals in Papua New Guinea used on during the peak COVID surge when Delta was around in September, October, November of last year, 2021. Some hospitals that typically would have used 40,000 litres per day consumed over 1 million litres per day. this is the main tertiary hospital in Port Moresby. Even a large provincial hospital in Mount Hagen, during the surge, the 1 month of Delta surge, used 90,000 litres per day, and smaller hospitals use less, but still is very substantially more than they had before. This is, of course, for adults and children, but as were the calculations that I made in 2012. So, and part of the reason for this was that there was a need for much higher flow rates beyond what concentrators can provide. Adults needed 10, 15, 20 litres per minute to with COVID to avoid hypoxemia. There were some possible solutions, and I think many of you will be familiar with this, but from the COVID crisis, especially during Delta in 2021, some more solutions. And one solution we thought was really worth looking at was the use of oxygen generators or plants, large essentially oxygen concentrators. So these are, there are many different types of these, moderate to very large, and I'd seen these in the northern provinces of Canada before, and I know that they run oxygen systems in many hospitals in China as well, and increasingly in African countries. These are, some oxygen generator plants can be transported in a container, such as this one. These again give an oxygen purity that's 93% or more typically, and this one, which can fit in a container, can generate 5,000 litres of oxygen per hour. So if you were to run it at 24 hours a day, that's 120,000 litres per day. But realistically, most hospitals will have the technicians to run such a plant for 8 or 12 hours a day, maybe a bit longer, but it's still about 40,000 litres per day. So even though this seems a very attractive proposition, a very attractive adjunctive option, it's still very substantially less than the huge amounts of oxygen that many hospitals were using during the surge of COVID, but certainly enough to manage a normal day when there's not a pandemic surge with lots of people, adults requiring oxygen. I mentioned there's some other options, including CPAP and high flow nasal cannula oxygen therapy as a way of reducing the amount of oxygen that's used. I won't talk too much about this, but there are systems and models for the use of CPAP and high flow that will reduce the amount of oxygen that is required when oxygen utilization is very high. There are relatively simple methods of providing CPAP. I won't go through this again. It's outlined in the WHO Oxygen Therapy for Children guidelines, and also it's I think well known to many of you, and there have been a number of studies on it. Now, the problem with CPAP in low-income settings, I think there are several, and we get used to in higher income settings, in better resource settings, we get used to CPAP being a relatively small intervention, but actually it's a very complex intervention, especially in a district level hospital. And I won't go through this too much, but recently we did a systematic review for the World Health Organization of looking at all the studies of CPAP in childhood pneumonia, and there are 3 large studies large randomized trials that have looked at this, and not all of them have been positive. And I think what it tells you is that the system has to be right for CPAP to work. Otherwise, it can be a potentially dangerous therapy unless you have the right context for delivering CPAP. So the implications from this systematic review there are situations where CPAP is safe, and that is in a high dependency area of a children's ward or in an intensive care unit where you have well-trained nursing and medical staff with the presence of a doctor on site and with at least daily ward rounds. Then CPAP is likely to be an effective therapy for children with severe pneumonia and hypoxemia despite standard oxygen therapy. I don't think it's a first-line therapy, but despite standard oxygen therapy, if children are still hypoxic, then CPAP is definitely worth trying. But in the absence of those conditions, then CPAP can be a potentially dangerous intervention, and most district hospitals are better off just giving oxygen as best as they can using robust and effective systems. The other method is high-flow nasal cannula oxygen therapy, and that carries, it's simpler than CPAP, but it still carries an element of system complexity that requires training and provision of equipment and infection control and procurement and replacement of damaged equipment and commodities and that sort of thing. You all know about high-flow nasal cannula oxygen therapy, which can be effective, again, in children that are failing standard oxygen therapy. The last thing I think we can take away from the pandemic is other lessons about respiratory care. And again, I won't go into this too much, but I'm sure you've all seen impressive results from prone positioning and in children and adolescents, adults with COVID. And I think that as we think about how to make most efficient use of oxygen and other respiratory supports, we shouldn't forget really basic things and physical interventions, if you like. And I think that prone positioning for the hypoxemic adolescent and adult has been remarkably successful. And it's not surprising to me that it's successful, because this is a child who has severe COVID, and this is the same child's CT scans with all this posterior consolidation and collapse, and you turn it up, turn the child prone, and you get much better aeration of those collapsed, consolidated areas. So COVID has taught us a lot about the provision of oxygen in low-income settings, how to do it better, and there are many salient lessons about respiratory care that we can take forward in the still COVID era, but as we continue to look after children with all of this changed epidemiology of acute respiratory infection. Thank you very much for your time.